So we have with us Dr. Sachin Thaisa. He's our first guest. He's a renowned orthopedic surgeon, a teacher, a researcher, and an author. He's widely respected for his contribution to academic orthopedics and scientific writing. So welcome, sir.
Thank you, Adame.
And next we have Dr. Arvind Vadkarsar. He is an accomplished orthopedic and spine surgeon, an academician, and a researcher with extensive experience in clinical research and publication. So welcome, sir.
Thank you.
Yes.
So, Tanmay, thanks for the introduction. Go ahead.
Yeah. So, with your permission, with your both permission, can we wait for a couple of minutes, like 2-3 minutes, or more people are joining right now?
No
Just
problem.
will wait.
No problem.
Yeah.
No. Also, we request the people who are joining, keep the microphone on the mute. So it is always better.
Yeah, so this I just wanted to give an overview in terms of why we are doing this talk. Is basically we saw in our clinical practice and with our friends and colleagues also that a lot of our orthopedic surgeon colleagues had very good data. For example, we had one of our senior colleague who was in Belgaum. He had such a nice data, but constructing that into an article, they never thought of it or they never had an opportunity to do it. And that's how we helped them into that. And now I think they have got about 4 to 5 very good publications in PubMed Index Journal. So this is how we go about. We form a group, we think collectively, and we have been able to do a lot of good research. And mind you, this is very simple uh, data which was collected by them, and we just help them into getting that published by just helping them. Nothing in terms of doing very extraordinary for them, but it is just perseverance and doing good help, and that's what has helped them to get good publications.
Yeah, Arvind, you're absolutely right. So what I'll just give a little bit of brief introduction on our Maharashtra Orthopedic Journal. First of all, I'd like to thank Karne sir, the president of Maharashtra Orthopedic Association, Prashant Tonpe, the secretary of MOA. Also, special thanks to Abhijit Vahegaonkar and Sampath Dumbre Patil for showing the faith on me and giving me the responsibility of the editor of Maharashtra Orthopedic Journal. That is JTOS. This journal was doing well, but it had a little bit of gap, you can say. And good, our whole team now, editorial team is really well. 15 days back only we had one issue, and hopefully next 1 month we'll have one more issue. So today's brief introduction, Arvind told us, it is very simple. It will be a talk on by Arvind around 10 to 15 minutes. And then we'll have a lot of questions. And any questions, if you want to post, we'll try to answer as much as in our capacity. Just few lines on me, like a research idea is always by the curiosity. And this, that you don't have to be extraordinary. I feel the biggest barrier in doing a article writing is planning and methodology, and which Arvind is going to put up how to write it, how to do it, how to have a master chart. And without wasting much time, I'll hand over to Arvind for his talk, and then we have an interactive session. Over to you, Arvind.
Thank you, Sachin Kale sir. I would like to give special thanks to MOA and Karne sir and Dr. Sachin Kale to give me this opportunity in terms of presenting this talk of how to prepare an original article. Dr. Sachin Kale has helped me to prepare this talk additionally. So let's start with it. So in terms of opening questions and identifying research ideas, so what is the first sign that a clinical observation is worth converting into research? First is it should be reproducible. That a lot of surgeons should know about it, and it should be they should be able to reproduce it. There should be a clear clinical impact. And lastly, you should yourself have a passion in terms and be curious in terms of investigating. A very simple example is, will chewing gum, if given to the patient post-operatively, decrease post-operative vomiting and hasten opening up of bowels? This is a very simple clinical observation. If we can do it, we can convert it into research. What stops clinicians from becoming authors for research is, first of all, a psychological barrier. So the first and foremost thing they should do is get out of their comfort zone. Second is time management. Every day you should at least dedicate about 30 minutes in a structured planning in terms of what you're going to do. If you have started a research, writing about it, or data collection, and it's a mind shift change. You should view publication as a professional duty rather than any optional extra thing you are doing. Okay. Now, can a simple everyday clinical question become a high quality original research? Absolutely. So the process, how you can do it is, first you observe something, then second is you question about it, you do a literature search about it, you find a hypothesis, and there you have the study design. So what I personally do is I keep a research diary. In terms of whatever question I have, I just keep jotting it down, and then I use websites like Consensus, where I just keep on questioning the consensus about whatever the research is present on that question. And if there is research question present, which is actually concerning about it, I read about it. The more you read, the more you will be curious, the more you will get good questions. So, for example, a questionnaire about the major obstacles about why ortho surgeons don't publish, that itself is a very high quality original article you can write about. What truly makes an original article is thinking independently and discussion with your friends. This single most thing, thinking independently, writing about it, and discussing with your friends, or a cup of coffee or a cup of beer, whatever you fancy, is the most important thing to make an original article. So, new data, if you keep on reading, you will understand new methods which you can get insights about with discussing with your friends and going to conferences, and application that adds to the meaningful knowledge. So for original article, a well-designed study on a common problem in your own population, for example, Indian population is highly original. So originality doesn't come from just, finding some out of the box idea. It also is adding value to the actually published article. Example, vertebral pedicle sizes in Indian population. So they have already studied in European population, but if you study in Indian population, it itself is an original article. Now let's find out how to choose a research question. So there are two things. First is the PICO, that is, you find out the population, you find out the intervention. If you have a comparison, then comparison, and lastly about the outcome. So it's a step-by-step process. Now the research question should pass through the finer criteria. Now what is finer criteria? It should be feasible. That means it should be reproducible and easily done. It should be interesting, it should be novel, it should be ethical, and it should be relevant. Okay. A focus question drives every subsequent decision in your study. The example you would be, now I as a spine surgeon do a lot of vertebroplasty. So once I thought in my mind, unipedicular, that means if I put a needle from one side versus bipedicular, does it actually result into better results in the patient if I do a unipedicular or versus a bipedicular? This is a simple question I had in terms of finer criteria and in terms of PICO. Now, how do you check whether the idea what you're thinking about has been already studied? So you do a systematic research. So there is PubMed, there is Google Scholar, there is Embase and Cochrane. So I personally, even at my level, I focus on PubMed and Google Scholar. And additionally, there is a new website which is known as Consensus. which I use quite commonly. Should young researchers select a fashionable topic or a common clinical problem? I think common clinical problems from your practice are far more valuable than taking any fashionable topic like artificial intelligence or robotic spine surgery. Rather than that, common clinical problems are far more easier to do and far more relevant. So, first of all, you should have the passion about that topic. Now, I had a passion in terms of doing erector spinae block. Now, I actually found out that this erector spinae block can also be given by X-ray guidance rather than those anesthetists doing it under ultrasound, which generally common orthopedic surgeons don't have. So I did an research in this with a common case series of only 10 patients and got it published in Journal of Clinical Orthopedics, which is a DOAJ journal. So these kind of common things can be done and can be also published. How important is the PICOT framework? Now, again, coming to the PICO or PICOT framework is basically you have the population, intervention, comparison, outcome, and then time. Okay. Now, let's give an example. So, in terms of population, it could be traumatic distal and radius fracture with the age group of 18 to 50 years. So, this is an young age group who has got a traumatic fracture. This is your population. Intervention is K-wire fixation. Comparison, what you can take is open volar plating, or you can put it as an closed distal and radius plaster stabilization. Now, what are the outcomes you will study about? Is you will study about the range of motion of the wrist, then the VAS score, that is a pain score, and lastly the DASH score. You have to get one or the other score which have been properly formulated and which have been properly authenticated for that fracture. And lastly, time, duration of the study. Whatever follow-up you are going to take, you have to take that. So this is a PICOT framework which you need to first establish before you start a study. Now let's plan how to do a study. So which is more valuable, a large study of a common topic or a smaller well-designed study? I would say both. A smaller well-designed study of an unanswered question that is novel, that also has its evidence value, and a large study of a common topic which is very easy in India. So example, distal and radius if you take, or you take a neck of femur fracture or an intertrochanteric fracture, you will get a large amount of patients for that, and doing something very peculiar in them is very easier, and that you can do in India, and it has got more evidence value. Now, what is a non-negotiable component of a research? First and very foremost is a clear research question. So you go with a PICOT criteria and find out what is your research question. Second is in terms of the methodology, what surgery you are going to do in that. And you have to be very consistent in what surgery you will do in that. You shouldn't be like, अरे थोड़ा सा इधर मैं चेंज कर देता हूँ उधर चेंज कर देता हूँ. No, you have to have a detailed methodology and you stick to the methodology. Third is the sample size calculation. So there is an sample size calculation I'll discuss in the coming slides. So we'll skip that for now. So then is the data keeping with a master chart. So this is very important. Is first when you are starting, first you have got a research question. Then you do is your data keeping with a master chart. I'll come forwards in terms of how to do a master chart. Lastly is the statistical analysis and ethics approval. If you are doing an thesis or an prospective study, you need to have these two, that is the statistical analysis plan and the ethics committee approval. Okay. How should the research decide the most appropriate study design? So I think as of now, if you are starting with any study, so the best would be to go for case series in which you describe a few number of patients, probably 10, 15 patients, in which you have done a similar intervention. The second or the most common and the most easiest is to do a case report. Okay, you get a single patient in which you had a fantastic result, in which you have done a very novel thing, you put a case report of that, and that will easily get published. So there are multiple journals like Journal of Orthopedic Case Reports, or even JTOS, our own journal of MOA, which is very welcoming in terms of you writing those articles, maybe it a case report or a case series. Okay, how early should a statistician be involved? Now, a lot of people have a lot of phobia in terms of अरे इसमें तो बहुत statistics लगेगा तो क्या करने. So mostly statistician is required in prospective studies. That means you are starting now and you are seeing the results over about 6 months time, in which you require a statistician. Or if you have a detailed research, like you are doing a systematic analysis, review, or you are doing a meta-analysis. But most retrospective case series, that means you have done a research before, or you are doing a data analysis. Sorry, you have put all your findings and from the previous records. If you are finding out that actually doesn't need any statistical analysis. Okay. Now, what are the common methodological mistakes that weaken a study? Inadequate sample size. So if you see, this is a website through which you can find out what is your sample size based on the prevalence in the population. So the prevalence in the population can be found out from the previous studies, and your study power of the study, what you want. So everything is fixed in that. You just find out the prevalence of the problem in the population from the previous studies, and then you can get the sample size. The second most problematic is the follow-up period. You should have a good follow-up period. You can't just say, I did this case and this case had good result. No, you should have a good follow-up period of at least till the bone unites, or at least till you get a significant outcome from that study. The third is not making a good master chart. So you should have a good master chart. In terms of master chart, you should have everything mentioned before you go for the study, and not following the standard method of treatment for all patients. So whatever method you have standardized for that study, you should take either only those patients in which you have done the proper treatment, a standardized treatment, what you have mentioned in your study, or you do a proper standard treatment for all your patients which are included in the study. Okay, that is very important. Can a poor studies design be rescued by excellent writing or advanced statistics? No. Garbage in, garbage out. You have to understand. अगर गंदा पहले से ही गंदा है तो वो गंदा उसका कोई आगे जाके अच्छा रिजल्ट निकलेगा ही नहीं. So invest in the good first study design, and then you go about. So the most important is to get a good study design by making a good master chart. So master chart is really important. Okay, how important is ethics approval, informed consent, and trial registration? See, in terms of ethics approval, if you are doing a prospective study or if you are doing a thesis, you need ethics approval. That is for the PGs to take. If you are doing a retrospective data collection and writing a case series about that, generally you don't need a ethics approval. Okay. In terms of informed consent, well, you have to take informed consent of each and every patient while you are doing a surgery. Just add one line that data can be used also for research purposes, and then your informed consent is over about that. Are negative results still publishable? Absolutely. Even if you say that a study had no difference between plaster casting and a K-wire in distant radius, even you get both results as same, that is also a very good publishable result. Okay, so don't think that. So if you take this example, there was an article which was published in National Journal of New England, which is NGM, which is a very highly regarded journal. in which they found out that THR versus hemiarthroplasty in a neck of femur in old age group both have same results. So this is negative results, but yet it was published in a very high good journal. Okay. So data collection and analysis. Now we'll come to this again. So how to make a master chart? For suppose if you are doing a article about distant radius, let's take distant radius. I am taking distant radius because that is one of the most common fracture we will come across. So you write about the demographics first. So first will be the serial number, name of the patient, sex of the patient, age of the patient, how was the method of the trauma, whether it was road traffic accident or fall. That is one. Then in terms of the surgery or whatever intervention, when was that done? Okay. Then you take pre-op parameters in terms of the VAS score. That means what was the pain at that point of time. Range of motion, generally it would be restricted at that point of time. So that might be empty at that point of time. If you have an old fracture, then you can write about the range of motion or any concern score. For example, if you're writing about the risk, then the dash score can be entered. Now, all these VAS score, range of motion, and any concerns specialized score, you take a follow-up at 1 week, 3 week, 2 months, and 6 months. So 6 months, generally it heals up. Probably it heals up at 3 months, but you add up 6 months because you will be doing some more physiotherapy, etc., etc. You add these scores, and at the end of 6 months, you will get an idea. You can also end it at about 2 months when it heals up. Okay. So this will give you a whole nice master chart. And once that master chart is done, you can also take help of your friends. You can also collaborate with your other friends in terms of getting this data of about significant patients. Probably about 30 to 40 patients is a good enough study. The first important thing is you do regular data audits and pilot testing with 5 to 10 cases. Okay, whether you are able to carry on with your data collection or not. If you are able to do 5 to 10 cases, do about 30 to 40 cases, or add your friend into that who can do about 20 to 30 cases, and boom, you have your own proper master chart on which you can easily do your research paper. Should data collection be handled by one researcher or multiple team members? Definitely you collab with that. So the good thing is if you collab with that with other your friends, maybe they are in your same city or other cities, like we have a whole Maharashtra over here. So if we collab with other researchers also, then what happens is becomes a multi-center trial. And if you have a multi-central trial, then it has a higher significance in the level of evidence. So should researchers select clinically meaningful outcomes? Yes, you have to. So if it is a wrist, you use a dash score. If it is a shoulder, you use a dash score again. If you have a spine problem, then you get osseous disability score. So you have to read a bit about these scores before you go about doing it. Also, in terms of the radiological features, so if you see in lumbar canal stenosis, you have some grading like Shiraz grading. So you use these gradings also in terms of your studies so that it gives you more reproducibility, which is the most important thing when you are writing an article. What is the clinical difference between statistical significance and clinical significance? So statistical significance is when your p-value is less than 0.005, that means the study what you have done and the hypothesis what you have put up basically. So that hypothesis, if it is true, it is very unlikely that it is just by chance. So that is the meaning of statistical significance. Okay. And what is the clinical significance? So if you have the difference which actually matters to the patient and the clinicians, which is a very subjective thing, that also has its own clinical significance. So you report both. You report the p-values also and the effect size also, which is mentioned in terms of the confidence interval and the MCID, that is the minimal clinical improvement difference. Okay, you mentioned both. Now, how much statistical knowledge should an orthopedic surgeon possess? So to be very honest with you, some simple things like p-value, confidence interval, power, you should know about that. And you should know about the simple tests like t-test, chi-square test. So t-test, it is a p-test. That is a paired t-test and chi-square test and ANOVA and regression. Even if you don't know, that is okay. But ANOVA, chi-square and paired t-test and unpaired t-test, you should know about that. Okay, and you can always use an statistician and you can use AI to understand this more easily. Now, writing in terms of the sections, what are the first? So first and the foremost, very easy is to write the methods. So you have done the research, you know what is the method which you have done. So you can easily write the method section first. Second is you write the result section. Now, what is the result section? Is whatever results you have got at the end of the study, you just write them properly. That is your result section. Then third, you write the introduction, and fourth, the discussion. Now, discussion is one of the most complicated thing to write. And lastly, you write the abstract from the whole thing and title. Okay. Now, what is the ideal structure of a strong introduction? Now, introduction, how you write is first you write general lines about, for example, if you write about, again, I'll take the example of distant radius. So first you write two lines about distant radius is one of the most common fracture. So you find out the research about what is the percentage in terms of the upper limb about that fracture. You write two lines about that. Then you come about the focused about distant radius fracture. So in distant radius, you will see that most of them have a lot of morbidity, malunion in terms of distant radius. Then you find out the lacunae. Suppose if you are comparing about uh, uh, casting and K-wire, then you find out the lacunae in terms of whether it has been previously studied. If it has been studied, whether it has been studied in the Indian population. These are the lacunae you try to find out. And lastly, you say, because this lacunae is there, that's why we are doing this study. Okay, so this can be just kept as about in 300 to 400 words. Okay, now how to write the methodology? Now, methodology, first you write about the design. So what it is, mostly if you are doing a case series, it would be a retrospective interventional study. If you are just observing the patient, then you say retrospective observational study. Okay, now who are the participants? Now the participants, you first write the age group. In study design, after that you write where your study is done and what is your timeline in which you have done the study. Then you write about the participants. So in terms of who are your inclusion criteria. So all patients who have got a distant radius fracture from this age group to this age group who have got a non-compound fracture. So it is a closed fracture. Okay, you write about that. Then in terms of exclusion, it would be opposite of that. The patients who have above suppose 50 age group, then I will exclude them. Who have got a compound fracture, I'll exclude them. Who are not consenting for the study, I will exclude them. That is your exclusion criteria. Then in terms of the intervention, you write that we did close reduction in this patient. Now, what are the outcomes you see? The dash score, VAS score, range of motion is your outcomes. If you are doing a randomization, then you write about the randomization and the statistical analysis plan. Okay. Now, what is a good discussion? Now, this is very important. How do you write a discussion? Okay. So, what you do is, first of all, in the first paragraph, you just summarize the results. Whatever you have got the results, you just summarize those. That's it. Then what you do is you find out all the papers which are similar to your paper and you try to find out the data from that. Then from that data, and you have to read those articles. Even 3 to 4 articles similar to that, you first download them, you read them nicely, and you jot down the points which are similar to your article and which are opposite to your article. For example, if you see in distant radius, some may say that it is more common in males. Okay, then you find out all the articles in which it is more common to males. in male population. So you write over there that based on our study and these studies, it was found out that it was more common in males. Then the method of injury, whether it was distant road traffic accident or fall at home, then you find out all those things, and you either say that in these studies it was similar to our study or it was different to our study. Okay, so this is how you go about with each and everything, and there you have the your discussion. Okay, then in discussion you write about the shortcomings of your study and your strengths of your study. So in strength, first you write about strengths. So what you write about strength is, this is a data of patients in Indian population. So that is very nice to write. Then if you have done a large study, then you say it is one of the largest, in terms of one of the largest. You never say largest, because there will be a lot of other studies which have been done about it. Okay, so you write about that is one of the largest in Indian population. Okay, or if you have done some tweaking in your methodology, you mention in your strengths at that point of time. Okay, then in terms of the shortcomings, you always say, okay, my sample size was a bit smaller. It was only a single researcher. We could have, and then you recommend that a larger sample size with more multi-center trial would be recommended. Okay, you just try to use the wordings so that you are able to write the strengths and the limitations. Now, why this is important in terms of writing the strengths and limitation is, when a reviewer is reading your article, he will try to find out what are the shortcomings in your study, and he will try to say, can you improve on those? So if you say already, okay, these are my shortcomings, ये मेरे को नहीं, इतना ही है मेरे पास, तुमको एक्सेप्ट करना है एक्सेप्ट करो, तुमको नहीं करना है मत करो, पर ये पहले ही मेरे शॉर्टकमिंग्स है. So he will be like, okay, he has mentioned, or he understands that these are his shortcomings, and then he will be more receptive in terms of accepting your article. Okay. Now, how do you compare findings with literature without merely summarizing? Is, as I told you, you first read the whole article, you find out all the important factors about it, which are similar and contrasting to your article, and then you write about it. Okay. Now, how openly should authors discuss limitations? As I told you, you write your limitations very openly, so that it helps the reviewer to understand your limitations, and it helps to decrease the chances of rejection of your article. What are the signs that the article has become too lengthy or unfocused? Is, first of all, you need to give someone else to read it. You give it to your friend to read it. If he says, "अरे बहुत पकाऊ लग रहा है, I couldn't read it," so you concise it. You try to make it more informative. You try to make it more focused, and you get feedback from your friends, and then you start writing. Okay. Now, what are the important things in the title and abstract? So the title is something like, it's a heading. So if you are reading a paper, the title newspaper, you always see the title first, and then you think whether I should read it forwards or not. Similarly, you should have a very catchy title. Okay, not in terms of how newspapers write, but in terms of it should give you the gist. In terms of, if you're writing again distant radius, so which is a better method of treating distant radius, casting or k-wire fixation? A series, a series of 50 patients. Okay, this is your title, what you can write about. Now, in terms of IMRAD, now this is how you follow. That is, first you write about the introduction. It is a very small introduction, about 1 or 2 lines when you're writing an abstract. Then you write the methodology in about 1 to 2 lines. This is again a concise part of whatever you have written before. So to be honest with you, when you're writing an abstract, you can just tell the chat GPT कि भाई ये मेरे results है या ये मेरा methodology है, इसको 2 sentence में लिख दो. So it will write in 2 sentences. Similarly, in results, you say these are my results, concise in 2 sentences. You can write your results. Okay, and then comes your discussion. So discussion generally has to be written in one or two writes, or you directly come to the conclusion in terms of the abstract. Now let's come to the authorship journals and publication ethics. Now, who genuinely deserves an authorship? So a lot of people will say, "Arey, mera bhi naam dal de, mera bhi naam dal de." So you have to be really ethical in this, in terms of whoever has contributed. Now, whose contribution you can consider as contribution? First of all, whoever has actively done the patients. So who has done the surgeries, who have done the data collection, those people will come. Second is whoever has thought about the idea of this research, his name has to come. Third is whoever has written the article, his name has to come. Okay. And whoever has revised or who has helped you formulate the whole research and the biostatistician, his name has to come into the research. Okay. Now, how it has to be decided, and whoever has done whatever work in that research, you have to mention that way in the end. Okay. Sorry.
Arvind,
Okay. Now,
you're doing great job. I think so we should finish in next two,
yeah,
three
yeah,
minutes. We have a good time to
I'm
discussion.
finishing.
Yeah.
Yeah. How to identify the most appropriate journal for your manuscript? I think like we have a very ready-made journal, that is Dr. Sachin Thaisa journal of MOA, which is very, very welcoming for you to publish your results. So you should first approach that journal. Then you have other orthopedic journals which you can approach. Should researchers aim for high impact or realistic ones? I think be ambitious but be realistic. So our journal of MOA is very welcoming. So definitely try to put articles into that journal. How to identify predatory journals and misleading invitations? So you will get a lot of emails about these journals. So if somebody is putting up that okay, publish in our journal, mostly you consider them as predatory journals. And you also check the indexing in PubMed, Scopus, and Web of Science about these journals, whether they are into that index or not. How serious is plagiarism? So you should never do plagiarism. You should never copy someone else and just mince with the words and put it, because you will get caught somewhere or the other, and that is going to cause you great loss of integrity, and sometimes you can be banned also in lot of places. Okay, so you shouldn't do that. Yes, you can use AI in terms of language polishing and structuring your arguments. Definitely, AI can be used in that. Okay. As a young author, how do you respond to rejection? Is wait for 24 to 48 hours before you take it personally and write something about it. But you should write, you should take everything as constructive. Even if you have got rejected, you read all the comments and make a plan for revising it and putting it again. Okay. Lastly, can a rejected manuscript be an important publication? Yes. Many landmark papers were first rejected before they found their home. So never give up. Haar nahi manne ka. Just keep on revising your article, revising your article. My first article, which is one of the most impactful article in my whole portfolio, was revised about 25 times. So you should understand that the more you're revising it, more you're making it better, and more it is becoming an important publication. Okay. So again, I think again I'll give a closing thought. India has a tremendous clinical volume and extraordinary surgical experience. So we should all compile that data and try to make our Indian research a global foundation for the whole medical evidence in the whole world. So I think that should be done, and the stepping stone should be our journal, JTOS, that is the Journal of Trauma and Orthopedic Surgery, where we are very welcoming for you to publish your research, and we are here to help you if anything is needed. Thank you. Thanks a lot.
Thank you so much,
Thank
sir.
you,
That
Arvind,
was a very
for
Sir,
informative presentation.
Sachin sir,
So,
yeah,
Dr.
Prashant.
Prashant here.
Yeah, Prashant.
Can I ask
I
sir any
yeah,
question?
First, I welcome Prashant, who is the
welcome,
secretary of
sir.
MOA, and also welcome Karne sir, the president of MOA. Yes, Prashant, go ahead. Please, we are happy to answer as
Sir,
much as
Vadkar
possible
sir.
the questions.
Yes,
Vadkar sir.
Professor. Yes.
So it is a very nice demonstration of your this thing, how to do like right. And just we are of our from Marathi medium. Like I think you also from Marathi medium here from Maharashtra. Vadkar.
Yes, yes. नाही
So
बोला ना सर,
the
काय झालं?
language problem is there for the writing. So sometimes we are picking the words, picking the sentences. So how to avoid plagiarism?
So in
Hello.
terms of plagiarism, sir, what I
Ah.
would say is you write your own in your own mind whatever comes. Okay.
Okay.
You first write it and
Ah.
you make a whole introduction about it. But before writing, you have to read. So you read and you make notes. जसं आपण शाळेत
Read.
करायचो ना की
म्हणजे दुसऱ्या
आपण वाचायचो
जर्नल्स मधल्या
आणि
आपल्या
नोट्स
रिलेव्हंट जर्नल
बनवायचो.
मधल्या हॅलो
हा हा
रिलेव्हंट जर्नल मधल्या यू हॅव टू रीड फर्स्ट
रीड फर्स्ट आणि नोट्स बनवायचे. ठीक आहे. आणि नोट्स बनवायचे आणि स्वतःच्या लँग्वेज मध्ये लिहायचं. कधीच प्लेगरिझम होत नाही. आणि झालं पण
वी हॅव लॉट ऑफ डेटा. म्हणजे आपल्याकडे आमच्याकडे डेटा एवढा खूप आहे. सगळे व्हिडिओज आहेत, पिक्चर्स आहेत, बट we can't reproduce in form of our paper and like in a reputed journal we can't send it like that. Because of this problem, I don't know how to do it.
सर मी तुम्हाला तेच सांगतोय ना
I
की
hope Prashant.
पहिले टोन पे सर द फर्स्ट फॉरमोस्ट थिंग इज यू रीड. म्हणजे 3 ते 4 आर्टिकल सिमिलर, आता डिस्टन्स रेडियस असेल किंवा मग स्पाईनचं वर्टिब्रोप्लास्टी असेल तर त्याचे पहिले वर्टिब्रोप्लास्टीचे पूर्ण 4 ते 5 आर्टिकल काढायचे, पूर्ण चांगल्यापैकी अभ्यास करायचा त्याचे नोट्स बनवायचे. त्याचे नोट्स बनवून मग त्याच्यानंतर तुम्ही तो तुमच्या भाषेत लिहायचा. फक्त टाईप करत जायचं. तुमच्या भाषेत जे काही तुम्हाला वाटतंय टाईप करायचं अँड यू कॅन देन पुट इट इन टू द फॉर्मॅट व्हॉट यू नीड. ठीक आहे. द गुड थिंग इज व्हॉट यू कॅन डू इज देर इज अ फ्रेमवर्क. म्हणजे इंट्रोडक्शन मध्ये की जनरल टॉपिकवर 2 सेंटेन्स आले, त्याच्यानंतर तुमच्या कन्सर्न टॉपिकवर 2 सेंटेन्स आले, त्याच्यानंतर लॅक्युनी काय आहे रिसर्च मध्ये ह्याच्यावर 2 सेंटेन्स आले, आणि त्याच्यानंतर मी हा रिसर्च करतोय, हेन्स वी आर डुईंग द रिसर्च. झाला तुमचा इंट्रोडक्शन.
नाही पण माझा प्रॉब्लेम फक्त जर डिस्कशन मध्ये येतो. डिस्कशन मध्ये आय कॅन डू इंट्रोडक्शन. आय कॅन राईट द मटेरियल्स अँड मेथड्स. मी कुठल्या पद्धतीनं करतोय ते पण मी कॅन राईट. बट डिस्कशन मध्ये एव्हरीथिंग वी हॅव टू जस्ट कम्पेअर इन दिस जर्नल. दिस आर दिस स्टडी अँड दिस इज आवर रिझल्ट लाईक दॅट. म्हणजे ते हाऊ टू अनालाइज अँड हाऊ टू राईट इट. आय एम नॉट गेटिंग कंपाइल इट. सॉरी, नॉट अनालाइज.
प्रशांत ह्याच्यासाठी आहे ना, नॉर्मली तसं अरविंदने सांगितलं की थोडा स्वतःहून वाचून अभ्यास केला, थोडा पॅशन दाखवलं थोडंसं, आणि थोडंसं मेंटरचा हेल्प घेतला किंवा आपल्या फ्रेंड्सचा
AI
हेल्प
will
घेतला,
help नाही.
दॅट विल बी रिअली सॉल्विंग द प्रॉब्लेम. See, AI should not be used for this predominantly. Our originality, AI is just for a grammatic things. AI तुला 10 मिनिटात 10 सेकंडमध्ये predominantly AI आपला 10 सेकंडमध्ये काहीतरी देतं, पण यू हॅव टू रीड 100 टाइम्स बिफोर एक्सेप्टिंग दॅट, बिकॉज AI
एक्झॅक्टली.
can give any information,
त्याच्यात
very
मी
vague
एक
information.
तुम्हाला
Abhijit is waiting. Arvind.
Can we
Let
quickly go
Abhijit
to
come in.
Abhijit, sir? He wants to
Abhijit
ask
is waiting for a
something.
long time.
Yes, sir. Yes,
Yes,
sir.
sir.
Good evening.
Thank you, sir.
Thank you so much. So first and foremost, I'm sorry I joined late. I was in surgery. Regarding Prashant's question on plagiarism, so one of the commonest reasons why a paper gets rejected is, of course, number one, plagiarism, and second is the use of AI now these days. So AI-generated papers.
Yes.
So there are umpteen number of websites and online tools that help you with the plagiarism. And the funny part about plagiarism is that you actually cannot you cannot even use your own paper if you're published on a similar topic, you cannot use more than some percentage. I think it is some 10 or 20% of your
Yes.
previous paper in the new paper. That also is plagiarism. So you cannot say, you can cite your paper, but you cannot really verbatim quote paragraphs, or you cannot take verbatim sentences from your previous paper into the
Paper.
new paper.
Yeah.
And you need to perhaps rephrase it. So that way you can perhaps,
No,
tide
just
over
sir,
the.
Yeah.
sir, I totally agree with you, sir. But just query. So I suppose I wrote on one type of method to do the ACL reconstruction. Okay. So that is, my paper is already ready and okay, already published. But I wanted to now publish another paper, ACL with meniscus injury. So my that ACL ka jo all that words and paragraphs will be there only now with meniscus injury, how I am treating. That will only extra added. त्याच्याबद्दल कसं सांगणार सर?
नाही
सर मी
प्रशांत आता
तुम्हाला तेच सांगतोय ना, whenever you
हा
are writing ना, you have
हा
to write on a piece of paper or you just type whatever comes in your mind. So
हा
जसं आपण बोलतो ना की मी एकदा लिहिलंय आणि मी त्याच्यानंतर परत एक 6 महिन्यानंतर तेच लिहितोय, तर आय विल नॉट बी एबल टू राईट द सेम थिंग बिकॉज आय विल नॉट रिमेंबर. कॉपी पेस्ट तर नाही करणार मी, बरोबर आहे की नाही?
हा
तर जे काही तुमच्या मनात येत आहे ते प्रॉपरली जर तुम्ही लिहिलं आणि सेकंड टाइम जेव्हा तुम्ही काहीतरी करताय तर यू आर डुईंग समथिंग न्यू, राईट? सो यू आर नॉट
ओके
गोइंग टू डू द सेम पेपर, इजंट इट? सो
ओके
त्याच्यात डिफरन्स येणार, तुमच्या रायटिंग मध्ये डिफरन्स येणार. आणि जसं तुमच्या रायटिंग मध्ये डिफरन्स येणार सर, तसं तुमचं प्लेगरिझम मायनस होणार. सो यू हॅव टू राईट ऑन युअर ओन. दॅट इज द होल जिस्ट ऑफ इट. AI will help you in terms of formulating the ideas, but you have to write on your own. That is the most important thing, sir.
ओके सर.
प्रशांत, जसं एआयचा
हा
जेवढा कमी वापर करता तेवढा बरं आहे. तसं आता हे एक क्वेश्चन तू
नाही मी तेच
विचारलास की
विचारतोय ना.
जे क्वेश्चन एसीएल आणि मिनिस्कस, हा एसीएल हा वेगळा भाग झाला, मिनिस्कस हा वेगळा भाग झाला. सो डोंट गेट
बरोबर.
कन्फ्युज. आणि लाईक एक्झाम्पल मिनिस्कसमध्ये पण कुठे रिपेअर करणार, कुठे मेनिसेक्टमी करणार. सो देर आर डिफरंट. सो युअर टायटल, जसं
आय
अरविंदने जे
अग्री
5-6
ना.
पॉईंट्स टाकले, म्हणजे कशा
हा
टायटल्स हॅज टू बी व्हेरी क्लिअर. द इन्क्लुजन क्रायटेरिया, द एक्सक्लुजन क्रायटेरिया ऑफ युअर आर्टिकल्स हॅज टू बी टू द पॉईंट. And then there should
हा
be a clear cut message, especially like a clinical message, and conclusion should be there. So हे जर बरोबर केलं मेथोडॉलॉजी, तर डिस्कशनला एवढा इश्यू येणार नाही, रिझल्ट्स ऑन डिस्कशनला. आणि वन्स दॅट इज देअर, देन द कन्क्लुजन अँड द लर्निंग पॉईंट ऑफ व्ह्यू विल जाईल. सो दॅट्स नॉट अ बिग डील. डोंट वरी. हे थोडंसं 4-5 वेळा आपण केलं, रिवाईज केलं. जसं अरविंदने 25 वेळा ते आर्टिकल रिवाईज केलं होतं, तेव्हा त्याचं एक्सेप्ट झालं. तर वी शुड नॉट गिव्ह अप अँड वी शुड हॅव द आर्ट ऑफ लर्निंग. ते करायला लागेल.
एक्झॅक्टली. हा थँक्यू सर.
Yes, sir.
थँक्यू सर.
करणे सर
थँक्यू
काय
अभिजित सर.
बोलायचं? कसं होतं अरविंद, लाईक लेक्चर हे रिझन फॉर प्रेझेंटिंग दिस डुईंग दिस सेमिनार वॉज दॅट पीपल शुड नो की एक बेसिक आर्टिकल कसं लिहायचं, पहिली गोष्ट. आणि त्याचे काय हे होते, लाईक एक्झाम्पल ॲबस्ट्रॅक्टमध्ये काय काय गोष्टी पाहिजेत, इंट्रोडक्शन, मेथडॉलॉजी, नंतर डिस्कशन, रिझल्ट्स, कन्क्लुजन आणि लर्निंग पॉईंट ऑफ व्ह्यू. रेफरन्सेस पण आपलं बँक्युअर स्टाईलमध्ये केलं तर बरं राहतं. सो दॅट दिस हेल्प्स फॉर द रिव्ह्यूअर ऑल्सो टू अंडरस्टँड व्हॉट यू वॉन्ट टू. वन्स लाईक एक्झाम सारखंच असं आहे, एक्झाम सारखंच आहे की तसा जो एक्झामिनरला आन्सर त्याला जे देता आलं तर ही विल गिव्ह गुड टेक मार्क्स इन रिव्ह्यूअर. बट इफ यू हॅव अ ब्लॅक पॉईंट ही विल से नो, आर्टिकल इज रिजेक्टेड. दॅट्स द वे. येस, गो अहेड अरविंद.
बघा, जर आता रेफरन्सेस इज अ व्हेरी टेक्निकल थिंग. सो त्याच्यासाठी वेगवेगळे सॉफ्टवेअर्स आहेत जे तुम्हाला वापरावे लागतील. एंड नोट झालं, रेफरन्सिंग झालं. आता व्हॉट आय जनरली यूज इज अ पेपर फाईल. सो इफ समबडी तुम्हाला जर पाहिजे तर पेपर फाईल म्हणून एक एक्सटेन्शन येतं गुगल डॉक्स मध्ये. So that is a very helpful way to write or reference your articles. So if you want, I can take a special lecture on that in terms of how to put different type of referencings into your article in Google Docs. Okay. So I personally do everything in paper file. So I can teach you that if needed, but it is very technical. म्हणजे तुम्हाला बसून सगळं ते करत राहायची गरज नाहीये. Now there are proper softwares for that, and you should use those softwares when you are doing referencing, not while writing, but doing referencing. You can do that. The second thing I would like to say is there are some AI tools which can be used for data extraction from articles. Suppose now you have 10 articles about vertebroplasty or about T-lift, and you are trying to do discussion about it. What you can do is you can use notebook LM. ते सगळे तुम्ही त्या notebook LM मध्ये टाकायचे. Notebook LM will
अरविंद थोडा
extract the
थोडा
data.
थोडा इथे इंटरप्ट करतो मी. जे डोंट लाईक आपल्याला म्हणायचं the address has to be that your article has to be original, your own thoughts, your own data, your own
Let me
data. And
complete.
हे
Let me
जे
complete.
yeah, okay.
Let me complete. Is you will extract the data from it into a tabular form, and then you compare that tabular form data with your own data, and you write the similarities and the differences of that data in your discussion. Okay.
अजून
So
कोणाला काय
you
प्रश्न आहेत? नितीन पाटील सर आहेत वाटतं तिथे. सर तुम्हाला काय बोलायचं आहे? तन्मय तुला काय प्रश्न विचारायचे आहेत?
Yes, sir. Very quickly, I'll ask you. We see a lot of orthopedic surgeons. They have good clinical data, but what I've observed is by talking to so many people that there is a certain kind of fear, or they are hesitant to how to go about things. So any advice that both of you can give to
just do it.
such people? Yeah.
Start writing. Start writing. Start
ऍक्च्युअली
writing.
तेच तर बॅरियर आहे ना. हेच तर बॅरियर आपल्याला तोडायचं आहे.
Actually.
की कसं आहे ना, जसं आता अरविंदने एकदम चांगली स्लाइड सांगितली की पहिलं
Hmm.
आपलं जे मेथोडॉलॉजी आहे, वाय वी आर नॉट रायटिंग आर्टिकल्स. द रिझन वाय वी आर नॉट, कारण आपण कोण करणार ते, तेवढं मंजनचं काम कोण करणार, तर डेटा आहे का
Hmm.
आपल्याकडे. अनलेस यू जम्प इन दॅट ओशन यू आर नॉट गोइंग टू स्विम. तर आपल्याला गरजेचं आहे की ते करणं. आणि स्टार्टिंगला चुका करणं काय होईल, वर्स सिनियर आर्टिकल रिजेक्ट होईल. अनलेस यू रिव्ह्यू युअर आर्टिकल, रिजेक्ट झाल्यानंतर आपण कसं इम्प्रूव्ह करायचं. आणि वी आर गोइंग टू इम्प्रूव्ह. जसं फर्स्ट इयरला पण आपण कुठे रेडियसलना लगेच येतं, म्हणजे सेकंड इयर थर्ड इयर मग लेक्चर झालं तर देन यू बिकम, आणि मोर अँड मोर यू डू रेडियसलना ऑर IT फ्रॅक्चर्स अँड दिस, अँड देन यू आर गोइंग टू डू इट. परत एकदा एक थोडं सांगायचं, जसं तू हा प्रश्न विचारलास की मास्टर चार्ट
Yes.
फार महत्त्वाचा आहे. त्यात मास्टर चार्ट बेसिक सांगतो. IT फ्रॅक्चरबद्दल मास्टर चार्ट करायचं असेल ते सिरियल नंबर, पेशंटचं नाव, एज, फोन नंबर, लाईक असं डेट ऑफ इंजुरी, डेट ऑफ इंजुरी फ्रॉम सर्जरी, असं एक पूर्ण असं प्रॉपर मास्टर चार्ट बनवलं विथ एक्सरे. सो दॅट वन्स यू हॅव दॅट मास्टर, वन्स यू हॅव डेटा, देन डेटा इज किंग. मग तुला त्याच्यावर देन व्हॉट यू वॉन्ट टू राईट, व्हॉट इज युअर क्युरॉसिटी टू राईट दिस पेपर, अँड यू कॅन डू. दरवेळेस नवीन करायचं, नॉवेल करायचं असेल अर्थ नाही. जसं अरविंदने स्लाईडमध्ये टाकलं होतं, देअर शुड बी सम मेसेज इन दॅट. Arvind, you want to add up something on this?
So I think like I have seen a lot of I review a lot of people who are doing their studies also. तर त्याच्यात जसं काळे सर बोलले ना, मोस्ट इम्पॉर्टंट इज द मास्टर चार्ट. जर तुमचा मास्टर चार्ट मस्त असेल ना, तर आता तर तुमचं जी स्टडी आहे ना ती खूप इझी होऊन जाते. ठीक आहे. नाउ आय एम जस्ट गोइंग टू शेअर माय स्क्रीन अगेन just to show how a master chart is actually created. Okay, so दिसतंय का?
Oh, Arvind, go ahead.
एकच मिनिट. So can you see this?
एक्सेल
Yes,
एक्सेल
we
मध्ये
can.
हा, तर हे बघा, सिरियल नंबर झालं, पेशंट आयडी झालं, नेम, एज, सेक्स, डेट ऑफ द सर्जरी, कोमॉर्बिडिटीज, सेंटर कुठे केलं, ASA क्लास काय आहे, BMI काय आहे. सो दिस इज फॉर द इरेक्टर स्पायनल ब्लॉक. आय हॅड मेड दिस मास्टर चार्ट. तर आता मास्टर पेशंट झाले याच्यात, त्याच्यानंतर USC गायडेड झालं आणि एक्सरे गायडेड झालं. तर ह्याचं सगळं हा असा वॅस स्कोरचा वगैरे असा मास्टर चार्ट येतो. एकदा तुम्ही छानपैकी मास्टर चार्ट बनवला ना की मग तुम्हाला बाकी सगळं डेटा एकदा टाकला, मग त्याच्यातला वेदर यू आर युझिंग दॅट डेटा, यू आर नॉट युझिंग दॅट डेटा, दॅट इज सेकंडरी. बट एकदा तुमचा मास्टर चार्ट चांगला असेल ना, तर मग बाकी तुम्हाला सगळं इझिली करता येईल. दॅट इज व्हॉट आय वॉन्टेड टू मेन्शन.
मला असं वाटतं जे मास्टर चार्ट आपलं 50 ते 60% काम करून देतो, आणि
Yes.
त्यानंतर मग पुढचं काम जरा सोपं आहे बेसिकवर. म्हणून तर आता मला वाटतं बरेच गव्हर्नमेंट कॉलेज आणि प्रायव्हेट कॉलेजने BCBR एक्झाम कंपल्सरी केलेली आहे. तर त्यासाठीच केली होती की ॲटलीस्ट वी शुड नो बेसिक नॉलेज ऑन रिसर्च. आणि मे बी रेसिडेंट्सला तर कंपल्सरी झाले की वी हॅव टू पास, अँड इव्हन फॉर द प्रमोशन पॉईंट ऑफ व्ह्यू रिक्वायर इट. सो ऑलवेज हॅव्हिंग अ नॉलेज इज गुड. यू हॅव टू बी लिटल पॅशनेट अबाउट दॅट. म्हणजे तुम्हाला थोडी इच्छा झाली पाहिजे. येस तन्मय, तुझ्या अजून 1-2 प्रश्न होते.
Yes. Sir, we see nowadays a lot of articles being published in a variety of journals. There are so many journals, so many articles here. So, what, according to you, truly makes an original article original?
So
I mean, how to preserve the originality, because there is so much data, so many papers being published.
to be honest with you, ते म्हणतात ना, ब्युटी लाईज इन द आय ऑफ द बिहोल्डर. तर इट
Right.
टोटली डिपेंड्स ऑन हाऊ यू वॉन्ट टू पोर्ट्रे दॅट दिस इज ओरिजिनल. ठीक आहे. आता काही जण इंडियन पॉप्युलेशनवर पूर्ण एक सिरीज बनवून टाकतात. काही जण व्हेरी सिम्पल टॉपिक. आता समजा आपण कॉटरी वापरतो, ठीक आहे, इलेक्ट्रो कॉटरी वापरतो. ते इलेक्ट्रो कॉटरीमध्ये आपण जे टिपला लावतो, म्हणजे आता आय डू लॉट ऑफ स्पाईन, तर त्या इलेक्ट्रो कॉटरीला पुढे मी एक हब लावतो त्या ह्याचं फिडिंग ट्यूबचं. त्याच्यामुळे माझं जे पूर्ण एनर्जी आहे त्या इलेक्ट्रो कॉटरीची ती फक्त टिपला राहते, अँड माय डिसेक्शन बिकम्स इझियर. If you are curious about that, you can write about these topics also. Innovations in spine surgery. Okay, simple innovations in spine surgery. So असे काही ना काहीतरी अतरंगी गोष्टी सगळे करतात. सगळ्यांचे काही ना छोटे छोटे हे असतात की अरे आय डू दिस बिकॉज दिस हेल्प्स मी मेकिंग द सर्जरी इझियर. आय डू दिस. ह्याच्यावर पण तुम्ही लिहू शकता. दीज आर इनोव्हेशन.
तुला थोडंच अरविंदने उत्तर चांगलं दिलं. थोडक्यात सांगायचं म्हणजे ओरिजिनल म्हणजे असं काही नवीनच नाही पाहिजे. ओरिजिनल म्हणजे जे आपल्याला हेल्प करतंय इज कॉन्ट्रीब्युटिंग फॉर क्लिनिकल प्रॅक्टिस, ॲडव्हान्स नॉलेजसाठी. सो ओरिजिनल म्हणजे लाईक यू कॅन हॅव अ मल्टिपल थिंग्स. तिथे त्या कॉस्ट इफेक्टिव्हिटी, तर ओरिजिनल लाईज इन अ क्वेश्चन असं मला वाटतं त्यांना आन्सर, की इट इज जस्ट टू नो की ह्याचा अर्थ काय आणि याचा कन्क्लुजन काय आणि लर्निंग पॉईंट ऑफ. सो डोंट गेट कन्फ्युज. परत बऱ्याच जण ओरिजिनल म्हणजे काय, नवीन काहीतरी करायला पाहिजे, हे तर झालंय की ह्याच्याबद्दल काय, असं काही नसतं. सो दॅट इज अ थिंग. येस, अजूनही कुठले प्रश्न? विल टेक 1 or 2 क्वेश्चन्स अँड देन मी वाइंड अप, कारण 10 वाजलेत. या.
Yes, sir. Yes. So, as Arvind sir had discussed that garbage in, garbage out, that is frequently said about research data. So, what systems can prevent incomplete or unreliable data collection? I mean, how to go about things?
तर मला याच्यात वाटतं अगेन मास्टर चार्ट. तुम्ही जर मास्टर चार्ट पहिले बनवला चांगल्यापैकी आणि यू स्टिक टू दॅट अँड यू डू अ ऑडिट ऑफ युअर 5 to 10 केसेस, की बाबा तुम्ही प्रॉपरली तो मास्टर चार्ट फॉलो करताय की नाही करताय. जर तुम्हाला असं वाटतंय तुमचा फॉलोअप जास्त होत नाहीये किंवा 2 महिन्यानंतर पेशंट घेत नाहीये, देन यू कर्टेल इट टू 2 months ओनली, किंवा 2 महिन्यातच पेशंट ठीक होत आहेत, तर यू शिफ्ट टू 2 months अँड युअर मास्टर चार्ट देन यू स्टिक. पहिले थोडा पायलट करायचा 5 ते 10 पेशंटचा, आणि त्याच्यात जर प्रॉपरली होत आहे तर मग देन यू स्टेबिलाइज युअर मास्टर चार्ट अँड यू स्टिक टू युअर मास्टर चार्ट अँड यू कम्प्लीट युअर मास्टर. दॅट इज रिअली इम्पॉर्टंट.
अरविंद जसा बोला मास्टर चार्ट फार महत्वाचा, आणि देन ऑलवेज यू कॅन टेक अ हेल्प ऑफ अ स्टॅटिस्टिशियन और अ डेटा मॅनेजर. दॅट इज फॉर ॲडव्हान्स. पण तसं पण आधी आता हे कोण करणार, कुणाला वेळ आहे, ते पण असा विषय निघतो बराच. कारण प्रॅक्टिस करायचं का हे करायचं, ते तसं म्हणाल तर सगळं ॲडजस्ट होऊ शकतं. डझंट टेक. तसं एक मॅक्सिमम टाईम मी तर म्हणेल 2 तास आठवड्याला पण दिले तुम्ही, तरी तुम्ही एक चांगला डेटा बनवू शकता. फक्त डेटा एंट्री करणं फार गरजेचं आहे. अँड अगेन मास्टर चार्ट हॅज टू बी गुड. दॅट्स द
And yes, yes.
I would definitely add that एकाने होत नाहीये. हॅव अ टीम. ओके, 2-3 तुमच्या ह्याच्यातले जे हू हॅव दॅट काइंड ऑफ अ पॅशन or who really want to write, make a friend group, make a WhatsApp group and put the thing into that group आणि त्याच्यानंतर करा. आता मलाही आठवत नाही आता माझे किती ग्रुप्स आहेत ज्याच्यात आम्ही रिसर्च करतोय. सचिन काळे सोबत इतके ग्रुप्स आहेत, बाकी मित्रांसोबत इतके ग्रुप्स आहेत. बट मेक अ ग्रुप अँड स्टार्ट डुईंग दो स्टडीज अँड दॅट विल रिअली हेल्प. एकाने मग तो टेम्पो पण राहत नाही, ते पॅशन पण राहत नाही आणि ते निघून जातं. सो हॅव अ ग्रुप अँड डू इट.
तर एक क्वेश्चन, लास्ट क्वेश्चन. तर सॅम्पल साईज मिनिमम किती असली पाहिजे? आता माझ्याकडं मी एक आता नवीन स्टडी स्वतः चालू केलेला, नॉट एनी कुठं वर्ल्ड मध्ये पेपर पण नाही असला, तर त्या स्टडी मध्ये फक्त माझ्याकडे आता 7 केस झाल्यात. तर ते तेवढ्यांचाच पेपर आपण प्रेझेंट करू शकतो का? लाईक पेपर तयार करू शकतो का?
प्रशांत, पहिले सॅम्पल साईज हा जरा वेग झाला मला असं वाटतं. जर तुझे जसं तू आता बोला की नाही ॲग्रीड, जसं तू म्हणालास की ही नॉवेल टेक्निक आहे, सो यू आर ट्राईंग टू शो दिस टेक्निक इज नॉवेल, काहीतरी वेगळी टेक्निक आहे जी पब्लिशच नाही झालेली आहे. मग त्याच्यासाठी सॅम्पल साईज ऑल्सो, स्मॉल सॅम्पल साईज ऑल्सो इज गुड. असं काही गरज नाही की आपल्याला सॅम्पल साईज मोठीच पाहिजे. समटाईम see, having a more sample size, having a multi-center study, multiple surgeon study, it always adds the value. But if the technique is innovative, novel, sample size could be less also. The sample size a particular हे नाही. Arvind is trying to show us something like what is should be
Yes.
roughly a sample size to be very precise. पण तसं मी म्हणालो की 10चं सॅम्पल साईज इरेक्टस स्पायनिचं 10चं सॅम्पल साईज होतं अरविंदची विच वॉज नॉट सो कॉमनली डन बाय दॅट मेथड आणि त्याच्यामुळे इट हॅड अ व्हॅल्यू.
बघा सर, हा एक कॅल्क्युलेटर डॉट नेट वर ना हा सॅम्पल साईज कॅल्क्युलेटर आहे. कॉन्फिडन्स लेवल तितकीच ठेवायची, मार्जिन ऑफ एरर तितकाच ठेवायचा, प्रपोर्शन ऑफ पॉप्युलेशन. आता समजा डिस्टन्स रेडियस पूर्ण पॉप्युलेशन मध्ये किती पर्सेंट मध्ये होईल, एक अबाउट मे बी 4 to 5% मध्ये ते होईल. ठीक आहे. आणि पॉप्युलेशन साईज इंडियाची काही असेल किंवा मग ते ब्लँक ठेवलं तरी तुम्हाला एक 73 तुमची सॅम्पल साईज येते. So if you have done 73 cases of distant radius, okay, so you can try to make a study out of it. तर जनरली 30 to 40 जर तुमचे असतील तर तुम्हाला प्रॉपर एक स्टडी बनवता येतो इफ दोज आर रेअर. आणि जर खूप कॉमन असेल तर मोर दॅन 50 मध्ये यू कॅन मेक अ गुड पेपर आउट ऑफ.
ओके, वन मोर रिक्वेस्ट अरविंद, तुम बोल तन्मय बोल.
Yeah. Sir, I would like to ask one question that might sound silly, but I'd like to ask it to both of you that should the title be attractive enough to capture attention? How important it is?
पिक्चरचं नाव चांगलं आहे पण पिक्चर चांगला पाहिजे ना. नाव थोड्या वेळासाठी चांगलं आहे पण अगेन सी दॅट दे आर बाय जनरेटिंग AI टायटल्स दे आर नॉट गोइंग टू सी युअर अगेन द स्टडी हॅज टू हॅव सम बेस अँड तसं सांगितल्याप्रमाणे इट हॅज टू हॅव समथिंग हेल्पिंग द क्लिनिकल नॉलेज अँड ॲडव्हान्सिंग द क्लिनिकल नॉलेज. तर मला असं वाटतं टायटल नेम सी इट हॅज टू बी असं हेफाजत नाही बट इट हॅज टू बी द पॉईंट. लाईक एक्झाम्पल फंक्शनल आउटकम आहे का, कम्पॅरेटिव्ह स्टडी आहे का, मेटा ॲनालिसिस आहे का, RCT आहे का, like the prospective आहे का, retrospective आहे का. So this has to be very clear so that when anybody is reviewing or you are also writing it, you are very clear message is there to the whole mass की what is your aim of the study.
सॅम्पल साईज तर आहे ना, मी आता फक्त 30 पेशंटची एका पेशंटचा इट इज अ नॉवेल टेक्निक आणि त्या टेक्निकनं मी एक पेपर प्रेझेंट केलेला. वर्ल्ड मध्ये फक्त एक एक सॅम्पल साईजचा हे होता, केस रिपोर्ट होता, म्हणजे ॲम्नियोटिक मेम्ब्रेन ऑगमेंटेड ACL रिकन्स्ट्रक्शन इन ऍथलीट्स. आणि ओनली आय टेकन ओनली रेसलर्स, फक्त कुस्ती प्लेअर घेतले होते आणि 30 कुस्ती प्लेअर मध्ये त्यात घेतलं होतं. आणि तो मलेशिया एकमेव वर्ल्ड मध्ये एकमेव पेपर येतो ऑगमेंटेड मेम्ब्रेनचा, तो मलेशियन जर्नल मध्ये प्रेझेंट झालाय माझा.
So that is a good thing.
हा 15 त्यात कम्पॅरेटिव्ह स्टडी होता, 15 त्याला मी ॲम्नियोटिक मेम्ब्रेन लावलं होतं, 15 नॉर्मल होते.
So perfect. जसं म्हणाला ना या प्रशांत जसं म्हणालो की सम स्मॉल सॅम्पल्स आहेत बट द टेक्निक इज नोवेल, समथिंग इज डिफरंट, डेफिनेटली वी कॅन. असं काही गरज नाही की ते करा, फक्त एवढं आहे की त्याचं लॉंग टर्म डेटा ठेवणं गरजेचं आहे. अँड अगेन हाऊ मच इट इज बी लाईक युजेबल बस. अँड इट शुड बी युजेबल फॉर द कॉमन मासेस. हे आहे. सो विल वाइंड अप. नितीन पाटील सर, करणे सरला मी बोलवलं होतं. बाकी नितीन पाटील सर आहेत, ते ऑलवेज एन्थुसियास्टिक असतात सर. सर तुमचे थोडे 2 कमेंट्स सर.
Yeah, it was a very useful and very comprehensive and elaborate talk till now I have heard on this topic, because it's very useful to the. Now we say that now you publish or perish. That's the famous sentence. You have to publish the things what you are doing. Otherwise you are not recognized. And for publishment, some protocol, some things, some rules, regulations has to be followed. That has been well elaborated in this talk, because the people have got they do very nice work. They have got the data also, but how to compile the data and to publish that or write a research paper, that many of 99% of the people they don't know. But this talk will definitely help to them. Very I thank to Dr. Vadkar and Dr. Kaya also for arranging such a beautiful talk. I wish both of you all the best.
Thank you sir. करणे सर आहेत सर.
नमस्कार सर.
Dr. Arvind, you have done a wonderful presentation, and this idea was in mind. Whatever Dr. Nitin Patil has just said is absolutely correct, because there are many doctors who don't have the infrastructure, institutional infrastructure, but are doing very wonderful work. And they want to present it, but they don't have any idea exactly, because nowadays, as you just have mentioned everything in your talk, There is specific pattern in which you should present your work, then only it is accepted at the international level. So that was my idea. So I spoke with Dr. Sachin that we should have such a presentation. This was in my mind for a few years, but somehow it didn't materialize. In a person like Dr. Sachin Kale or Dr. They come forward and they are doing this wonderful work. So it's a great thing which has been done. What I say that because of this was a webinar, we didn't have the adequate audience for this. But I suggest to keep this topic also in MAOCon as well as in our peripheral this CMEs. Say, for example, just recently this Sunday we had a spine conclave at Nanded. So that's one of the MOA program that we are going to do the spine program at every district places at a different month after every 1 2 month. Then same for the foot and ankle, same for the hand, everything arthroplasty, arthroscopy. So there I wish to keep one talk of this kind everywhere.
Yeah,
If it is not
definitely.
possible for you to come, then at least we'll give your recorded version there. But all those doctors who are come there, this is very, very important that if they have to remain in touch with the modern concepts of research as well as to have recognition at the national international level, they need to understand all these things. एक एखादा किती जरी बुद्धिमान असेल आणि तो जर 12वी परीक्षा पास नाही तर मेडिकल ऍडमिशन मिळणार नाही त्याला किती जरी असेल हुशार तरी he has to go through the proper protocol and this is necessary because people other will say I mean there are many people who are having tall claims right from Ramdev Baba to many other places, but it has to have some scientific base, it has to have some scientific protocol. So I really thank and I really am very happy that we have got such a enthusiastic persons, which was my dream that all persons of Maharashtra should come together and give their knowledge, share their knowledge and guide to all the peripheral orthopedic members. And this is happening. Very much thankful to all of you, Sachin, Arvind, and even Tanmay is there. And my Tanmay is one of the person who is having new ideas. So we are taking all, we cannot take everybody in the EC, but still we want, contribution from everyone. Dr. Nitin, you are also doing wonderful work at periphery and in academic college. So I request all of you to share all your efforts, your knowledge, your guidance to all the members in such webinars and the CMEs. Thank you very much.
Thank you, Karne
sir. We can do one more thing. We can upload this video on YouTube.
Yeah.
So that other people who have missed this talk, they can visit that and watch that video again and again. So it will be
it is a good idea.
circulated.
We are going to put this on our website immediately. After editing, we will see certain things and we'll edit it and we'll put on our website. First thing we'll do that also. And later on we'll put on the YouTube also. That is very good idea. We have got a YouTube channel. Tanmay, you have to look into those things.
Yes,
you
sir.
and
Yes,
Faisal
sir.
Khan. Okay,
Definitely. Yes, sir.
I think I have made, I don't know, I remember to whom I have made the in charge of the media and the social digital media in the MOA committee. Okay, so he will look after all these things and see to that all these things are there on the digital format on the MOA website also as well as on the MOA channel, YouTube channel.
Yes, sir.
करणे सर आपल्याकडे वेब मास्टर पण चांगले आहेत आणि असिस्टंट फैजल सर पण चांगले आहेत आणि तन्मय आहेत तर काही टेन्शन नाही. मी अरविंदला अजून एक सांगेल की ते थोडा अजून जे प्रेझेंटेशन थोडं प्रिसाईज करेल अजून एक म्हणजे टू द पॉईंट सो दॅट पब्लिकला ऑडियन्सला होईल.
अजून एडिटिंग करून
हा चालेल. आणि सर अजून एक गुड न्यूज द्यायची इथे की आपलं ते सेकंड इश्यू आहे अजून एक. आता फर्स्ट इश्यू मागच्या महिन्यात झालं आणि सेकंड इश्यू 15 दिवसांमध्ये मोस्ट लाईकली होऊन जाईल. तर 2025 सगळं संपेल अँड देन वी गो फॉर 2023. So that's the good news. And our editorial team is also helping us. So that's good. No problem. So we'll wind up, sir. Close.
Dr. Arvind Vadkarsar कुठले?
Sir, ते नवी मुंबईचे आहेत.
From which place?
From खारघर, sir.
नवी मुंबईचे ना. Very good. Yeah.
श्रीपाद पण आहे.
नाही तुम्ही सगळ्यांनी पुढाकार घ्या. डॉक्टर नितीन तुम्ही पण काहीतरी यू कम फॉरवर्ड अँड तुम्हाला कशात कुठल्या भूमिकेमध्ये भाग घेता येतो एमओच्या ऍक्टिव्हिटीज मध्ये तुम्ही सगळ्यांनी पुढे या. आपण प्लॅटफॉर्म निर्माण करू सगळे आणि प्रमोट करू. सो
मी
गो अहेड कीप इट अप.
बाकी मी थँक्स करणे सरांना आणि आपला सेक्रेटरी प्रशांतला अपॉर्च्युनिटी दिल्याबद्दल. आम्ही सगळेजण आमच्या 100% देऊया आणि आपला एडिटोरियल बोर्ड ऑल्सो इज हेल्पिंग अस. सो रिअली थँक्यू ऑल ऑफ यू.
Sir, again, I would like to say thank you to Karne sir, thank you to MOA, thank you to Sachin Kale sir. आणि जर कोणाला काही त्याच्यात प्रॉब्लेम असेल किंवा डाऊट्स असतील, how to go about, we are here to help you also in terms of how to go about with the articles, and definitely we can help you. So we are not going to write for you. That is not a good way to say about it. It is we will help you. हा बाबा असं करायचंय, तुम्ही असं करू शकता, हे करू शकता, ते करू शकता, तुम्ही असा मास्टर चार्ट बनवू शकता, दॅट वी कॅन डू फॉर यू, अँड दॅट itself will help them to get their first publication if may, or increase their publication numbers. So we can help in terms of that if needed, sir.
ही
Definitely.
आपली पंचलाईन पण आहे, MOA ची पंचलाईन आहे, रिसेंट पंचलाईन, की तुम्ही एक पाऊल पुढे, आम्ही तुम्हाला 10 पावलं पुढे नेतो, पण एक पाऊल तुम्ही
Perfect.
पडायला पाहिजे.
That's perfect.
या
Yes.
ही पंचलाईन आता आपण केलेली आहे.
Yes.
तर मॅम वोट ऑफ थँक्स देऊन टाक मग तू. मग त्याप्रमाणे
Yes, sir. So thank you so much, everyone. Thank you. Special thanks to Karne sir, Prashant Tonpe sir for this giving this platform and this opportunity. So that and through this webinar we can reach each and every corner of not just the state of Maharashtra but also the country, to all the young residents, to all the young orthopedic surgeons who are thinking of writing articles but they are somewhat hesitant. So this definitely will help them. So thanks a lot. Thank you to the Maharashtra Orthopedic Association and thank you. Thanks a lot. That was a very nice webinar.
Thank you.
Thank you everyone.
Bye-bye.
Good
Thank
night.
you and good night, everyone.
Good night.